We have about 20 to 25 minutes time for discussion. So you're kindly requested if you are addressing a question, mention to which speaker you are addressing your question. Please go ahead.
Thank you, Mr. Chairman. The idea of this session was to address the special issues that face an optimal management of patients with non-communicable diseases. There are two problems in managing patients. The clinical problem, how do I treat this patient as a patient, what kind of medication and dosage and what have you, and then there's the larger public health dimension. How do I make sure that everyone who needs treatment actually gets treatment? How do I make sure that everyone who needs to be detected and screened will actually get the detection and screening and management? And so this is really the conundrum that we were hoping our speakers in this session would address. So maybe if I can put back the question to Dr. Sanya Nishtar, who has been really in the field in a country with a whole lot of logistical difficulties. The communicable diseases are relatively easy to pay for. It's a finite cost. Someday everyone would be vaccinated. Someday everyone would be immune. We know exactly the number of children who will require how much cost, and that's a somewhat estimable cost. Non-communicable diseases are an open door. The program in Lebanon has been running back and forth trying to cover an increasingly larger number of people who are in need of diabetic treatment, of cancer drugs, and it's becoming very expensive. How do we solve the conundrum of giving the basic, equitable, quality care to everybody and not leaving anyone behind in terms of coverage? Any ideas?
Well, that's a very big question to answer, but you take it in different chunks, because of course when you talk about costs in non-communicable diseases, there's the cost of prevention, and there's a cost of action that needs to be institutionalized in that domain. Then of course there's the cost of the set of interventions which need to be introduced into primary health care. So that's where the workers' training, that's where essential medicines, that's where the service training, the introduction of other technologies are involved. And then of course at the third level, you talk about the costs, the catastrophic costs of care. A lot of people would like to put it in the tertiary category, but I would argue that many of them are essential treatments. So you look at them in three domains, and as far as the point about equity that you made towards the end is, ultimately it falls on the shoulders of governments to make the right priorities and to make the right allocations. Many of the developing countries in the Eastern Mediterranean region have appalling investments in health. The investments in health from the public standpoint are less than $20 per capita in many of the developing countries of the Eastern Mediterranean region. So you can't possibly aspire to cover the basic NCD services in primary care. You cannot aim for the basic package of preventive interventions that go alongside policy change. And of course, what falls under the rubric of catastrophic health spending and what needs to be covered under social protection arrangements is way beyond the minimum requirements. So it ultimately boils down to the priorities that governments have and the level of investments that they make.
And the resources. Please, do you have a question?
Thank you, all speakers. I have a comment which is really, in my opinion, very important and have been ignored all over the 3 days. And that we are always running behind. I did not hear any one of the speakers talking about pre-diabetes. That's where we have to start. We know, there is no doubt, that we get all the complication of diabetes in the pre-diabetic stage, and that's where the intervention is very cheap, very effective. The same thing applies to pre-hypertension and overweight. Even in our statistics, you look at all the statistics that we have seen, except from Jordan, that everybody is putting pre-diabetes aside and talking about diabetes. If we continue just to wait until we become obese, not to start when we are overweight, until we are hypertensive, not before we become hypertensive and diabetes. We should not wait until the person has diabetes. We should start treating this person with even drugs when he is having blood sugar 110, because he will get blind and he will have nephropathy, retinopathy, and all the complications. Why to waste these 10 years before diagnosis? Thank you.
Thank you very much for your comment, and I think everybody would agree that preventing diabetes is as effective as treating it. From the ladies there, we'll take a question.
Assalamu alaikum, Jawahar Fassam. Thank you very much for this important lectures. I got two questions. One for Dr. Randa. You mentioned that you give the medication free in the PCC. How much tax you do for the pay? How much tax in Lebanon? Is there tax and how much is it?
The second question, please.
Second question is for Dr. Shehri. You mentioned that you make the schools. How many schools and how much is the percentage of the schools in Saudi Arabia? How many schools were studied and the percentage of the in the Saudis?
Thank you. Ms. Landa, could you kindly answer the first question?
Yes. Thank you, Mr. Chair. I've already mentioned that there is collaboration between Ministry of Health and one of the NGOs in Lebanon to run and to implement this program. Accordingly, there is a yearly budget allocated to the NGO in order to buy medications based on the essential drug list and based on the opinion of the committee, the drug committee in the country, National Drug Committee in the country. So accordingly, the NGO buy the drugs and distribute it free of charge to the community or to the patient, NCD patient.
For example, in Europe, it is 30% of the tax, and they provide services.
Yeah.
How much is it in Lebanon?
But being NGO bringing those drugs to distribute it free of charge, no taxes would be put on those drugs to enter to the country. Ministry of Health will exempt them from paying taxes to the, they will buy it from outside and they would be exempted from paying taxes.
No, I mean yourself, how much tax you pay?
Yeah. I think
in general, how much tax in Lebanon?
There are two sources of revenue of taxation in Lebanon, direct and indirect. The direct it's a taxation on income revenues, and it's maximized to 10%. So it's gradual and reaches 10% and it's capped over. The other is indirect, and it's paid essentially through the value-added taxation, which is now at 11%, and I think the government has been discussing
Dr.
to
Shehri, could you
increase
answer the
it. So
second
these are the two sources.
Would you have the microphone to the second gentleman?
Thank you very much. I have a comment actually on the first question, if am I allowed. I think we will be very late if we have an intervention just before 10 years of developing diabetes or any other chronic disease. I think we have to start as early as possible through the schools. And I think we have an opportunity to invest on these population, school population, to prevent the chronic diseases. And we have started one, this program is the health promoting school program does actually prevent a lot of chronic diseases if it is implemented well. The question about the percentage of schools that implement health promoting schools, it's still around 2,000 schools, and we are planning to increase it or expand it 5% every year. It needs actually some logistics, and it needs planning.
Thank you, Dr. Shehri. Dr. Muqdad, quick comments before we take the next question.
I would like.
Go ahead, please. Go ahead.
I would like to address the question raised by Professor Ajlouni. I mean, I'm in total agreement with you. This is a very important point, and I hope it comes as one of the recommendations of this meeting here. So in our region, it's totally different than taking guidelines from the Caucasian and Western and the way we live, the way we eat, our eating habits. But what you're proposing is challenging in many ways. So one of it is, when do you call it's a case or a disease and you start managing it? Is it blood pressure, cholesterol, and diabetes? That's one. So you need the science for that. And we need to do some research in our region in order to determine the cut point where we start intervening, one. But we have enough information to act. We shouldn't wait. Second is early detection. In this region, we need to invest in early detection. You know in Jordan it's about 30% undiagnosed diabetes. How we get these guys to go and diagnose themselves so we could start your vision and your idea of early treatment. And how we set systems once we diagnose all these conditions to treat it and manage it. So a lot of work needs to be done, but I totally agree with you. Some big recommendations should come from this meeting about the case management and what we call a case of diabetes, blood pressure, and cholesterol in this region.
Thank you. Next question, please.
Thank you very much. I'm Mohamed Hassairi from Tunisia. I have just a comment for Dr. Suleiman about the methodology of his study. I think it should be better to have two assessments, the baseline assessment and post-action assessment, and after to compare the progress in the two groups. Because according to your methodology, I think it's difficult to conclude about the efficacy of intervention. Thank you.
Thank you. Questions there, please. Will you give the mic to...
Thank you to all excellent speakers. I'm Abdulaziz Al-Saif, Director of Medicine in Military Hospital for. I really appreciate what you are mentioning about medication. I know that there is about 30 insurance companies and health companies in Saudi Arabia. But when the patient coming with non-diabetic hypertension, they give him medication for very limited time. And the patient going and coming just to get for 2 weeks and so on. And this is really need regulation from the Ministry of Health. The other topic, the other important issue, we have 9 million foreigners. Who's taking care for them? Majority of them, they are not insured. They are not accepted in the primary health care system and so on, because they should be insured by the Saudi sponsors. I want really to make clear that the patient who is really chronically ill patient, he should take chronically medication and regularly with the basis that wherever he goes, even if he has no insurance, he should be given. Otherwise, one day he will be blind or amputated or so and so. Thank you.
Thank you, Dr. Saif, and I think we'll pass this comments to Dr. Ziad Miamish. He is the man in charge of the Ministry of Health to take it in consideration. Next question.
Thank you very much. I'd like to thank the organizer for such an intriguing and very intelligent discussion. My name is Asma Omar. I'm a consultant in clinical nutrition from the UK, England. I just want to make a comment. From the presentation by Dr. Raji, I could see that there's some sort of discrepancy in terms of the incidence of I lost my word.
Retinopathy.
Yeah, and retinopathy. You see countries, for example, like Emirates, Yemen, and he mentioned Jordan. They come to the top of the list. When we look at Dr. Renda's presentation, you see that coronary heart disease contributing to the majority of death in Lebanon. And yesterday, from one of the presentations, we also saw that countries like Qatar and again Yemen, they come to the top of the list. We suggest that when you look at it's nothing to do probably with income per capita or the expenditure, probably the modifiable factors will probably suggest that there's sort of different risk factors which contribute to the presentation or the existence of non-communicable disease. So what I would like to suggest is probably looking deeper to see which are the non-communicable disease more available, or the prevalence of non-communicable disease in different countries, to come with different policies and different strategies, rather than look at them at the whole as an umbrella, look deeper to see which one, and then take priorities accordingly.
Thank you for your comment. Dr. Rajhi, do you want to respond?
Thank you very much for your comment. Actually, what you've mentioned is the story of our lives. Just to tell you how tough it is to get, I mean, I hesitated a lot before presenting these numbers because I thought I would look like a fool when I present so many different variations in the numbers, even within the same area or the same economical status, or countries that are of the same level. But we have very limited data on ophthalmic diseases in the region, in the EMR region in general. Saudi Arabia, as an example, until the latest one that was done before the three RABs that we did with the Ministry of Health, and with the strong support, I might add, from the Ministry of Health, we had a gap of 18 years without any community-based studies or surveys in Saudi Arabia. So unfortunately, and just to let you know how tough it is, we have countries in the region, like for example Djibouti, until recently had 0 ophthalmologists, and now they have only 2 ophthalmologists in the whole country. So you can imagine that they don't even have anyone to do the surveys or the studies. So this is why you see these studies and these numbers that are so much variable. The design of each study is totally different. The population that they study is totally different. And some of these studies are done quite old, 15 years, 16 years, 17 years. So this is, plus we have and most of them are maybe, I don't know if you've noticed, but in the beginning of my presentation I said estimates. These are the best estimates that we have. So some of these data are based on national coordinators' estimates that they provide the WHO, and we take them based on multiple studies they have on smaller groups within the country. So these are not accurate numbers, and indeed there are so many discrepancies in our region. We have scarcity of ophthalmic research in the Eastern Mediterranean region. Very limited research, unfortunately.
Thank you, Dr. Rajhi. We'll have a question from Dave, please.
Dr. Murad, I am working in the Ministry of Health. My question to Professor Sulaiman Shehri on the children and youngsters in Denmark, they have physical activity 1 hour on a daily basis in school to prevent obesity and to reduce the risk of developing type 2 diabetes later on life. What we are doing as physical activity on daily basis in Saudi Arabia in our school for children. Thank you.
Thank you, Dr. Murad. Dr. Shehri, you respond?
If I understand, the question is
about
physical activities in the schools. I think, I mean, we have a long experience of physical education classes for the last, I mean, in boys' schools for the last maybe 45 years. And still we have problems with obesities and etc. The implementation of that is the important. And there's, I mean, Ministry of Education is embarking on a new strategy for the school sports, which is going to be implemented in the coming probably few years. And I think all the aspects, whether health or competition or sports, other objectives of sports in the schools have been taken in this strategy.
Thank you, Dr. Shehri. Dr. Muqdad, quick comments and then we'll have a question from this.
I'd like to answer the question of the colleague from Tunisia about surveillance. It's very important for us tackling non-communicable diseases. The view should be different than communicable diseases. Is to do integration of data. So in every survey, taking into account privacy and all, capture the national ID, al-Raqm al-Watan. And basically, if you have a good hospitalization system, good mortality system, you know what this guy goes to hospital for, you know what this guy will die from eventually in a long time. unless you do this integration when it comes to chronic non-communicable diseases, we're not going to have the full picture. Surveys will tell us the risk factors at the community level, but unless we link it, we're not able to do so. And we hope to do integration of health information system.
Thank you. We'll have a question from the ladies there.
Dr. Richard.
Thank you. I am Habiba Barramdan from Tunisia. My question is addressed to Dr. Muqdad. It's actually it's not a question, it's a comment. I would like to have your opinion. Secondary prevention is a little bit different from primary prevention in the way that secondary prevention is almost under the responsibility of
Habiba, we can't hear you.
Okay. I said that secondary prevention is a little bit different from primary prevention in the way that it's almost under the responsibility of the Ministry of Health and the Ministry of Finance. Secondary prevention is also cost effective, even in our countries. And the last study we conducted in Tunisia and Palestine, Syria, and Turkey show that secondary prevention is very cost effective. My remark is that how to push Ministry of Health to integrate the secondary prevention in the minimum package and in the universal access to treatment like it was done for vaccination or for water supply. Thank you.
Thank you. Dr. Nishtar.
Maybe I'd just like to connect back with what a colleague in the front row said about the importance of pre-diabetes and pre-hypertension. And I think that the point that we need to appreciate there is that there are broader-based, population-based preventive approaches that we invest in. And then on the other end of the spectrum, we think about patients and long-term care of established chronic disease. But in the middle of it are these conditions that are not apparent yet or are in a state of what you describe as pre-diabetes and pre-hypertension. And it is within that framework, it is within that space that there is a huge role of screening. Population-based screening, whether it is population-based screening for hypertension or whether it is high-risk screening for diabetes based on a set of different parameters that are locally relevant. And screening partly belongs to the population space and it partly belongs to the high-risk approach. And I think that there should be a conscious effort to ingrain it at the primary healthcare level and at the level of population policy. So thank you for underscoring the salience of that important point.
Thank you. We'll have a last question from the...
My name is Richard Smith from Imperial College London. I'd like to ask a question particularly to Sanya, but perhaps to the rest of the panel. It's a year now since the United Nations meeting, and I worry that we haven't really galvanized the public at all. I suspect were I to walk out of here and ask people in Riyadh, what do you worry about? Do you worry about NCD? They wouldn't even know what I was talking about, and it would be exactly the same in London. And that's where I think we're very, very different from the HIV/AIDS world. So what can we do to involve the public? My second question is, do you think it's a problem that actually we are stuck in the health ghetto? It seems to me. Everywhere, it's ministries of health that are responsible for this. It's WHO rather than any of the other UN bodies. And I feel that while we're stuck in the health ghetto, we're going to make very limited progress.
So,
well, thank you.
Go ahead, please.
Well, thank you, Richard. Again, two very important points. As I said when I had the floor, policy change comes with public demand. And if the public is not going to resonate with the messages that we think are important, they will be, the policymakers will not be compelled to make the right action. As far as creating the societal demand for change is concerned, I think we need to look at sectors outside of health. We need to look at the potential within behavior change communication, the tools that the advertising and the market industry leverage. There is a whole science behind that engine. How do you capture different segments of the market? How do you analyze what their behaviors are like? How do you invest in the appropriate strategies which will institutionalize change across the society towards certain things that are your goals? And I think that that level of competency, that skill set, that level of thinking, those instruments, that entire engine is lacking within the development community in general and for NCDs in particular. And I completely agree with you. If people demand low salt, low trans fats, smoke-free workplaces, and the rest of it that we're all talking about, there will be pressure on the policymakers to invest in that area. And then, of course, you talked about the issue of mandate. Clearly, this is something that is beyond the competency of the Ministries of Health, and clearly the UN system was very strategic in positioning it as a broader development goal. And that is the rationale why the United Nations General Assembly got involved. That is why there is this huge emphasis on the whole of government approach, the need for health and all policies. And I think that in a way this brings us back to the question of leadership. How do you get different sectors of the government excited and behind a particular goal when there are issues of turf wars and, you know, little domains that people are very, very sensitive about? So unless we get the Prime Minister or a head of state excited about this issue, and I think that is the whole thinking why, which has galvanized the development community to talk about the big economic numbers, you know, to talk about the things that really resonate with decision makers at that level. So I think that these two things that you talked about, Richard, are about the big paradigm shifts that need to happen in public health. The need to have the society calling for change and the need for leadership at a very different level to talk about the set of actions that are needed to achieve stated goals.
Thank you. And last comment from Dr. or question from Dr. Alwan, because we're running short of time for the break.
Thank you very much, Mr. Chairman. I wanted to respond to a very important 2 points by you, Richard. And this is on the role of the community and also on the role of the other parts of the UN. In addition to what Sania said, there are some very concrete steps to engage all UN agencies. In December of last year, there was a meeting in New York with all UN agencies. And as you know, most of these UN agencies were active participants during the high-level meeting of the General Assembly in New York. So a task force was established, which involved most UN agencies, particularly the United Nations Development Program. And there is a letter that was sent to all UN agencies in member states, particularly focusing on developing countries, signed by both the administrator of the UNDP, Helen Clark, and the Director General of WHO. The focus now is to integrate the basic components of NCD prevention into what we call the UNDAF. The UNDAF is a very important tool, which is the United Nations Development Assistance Framework. This is the plan that is developed in every developing country to support sustainable development. It's usually developed with the Ministry of Planning and involvement of non-health sectors. So there is now a strong movement to integrate NCD prevention into the work of other UN agencies and also within the UNDAF process that is ongoing and it's being updated in most countries. What we will do during the regional committee next month, and the regional committee is the annual meeting of Ministries of Health, which will be held in Cairo, is to present a table, a very clear table, identifying the exact roles of each of the United Nations agencies and what they are expected to do to contribute to the implementation of the political declaration. And what we are also trying to do, and this is something that we have already initiated, is to organize a meeting with all resident coordinators of the UN system in this region, in the Eastern Mediterranean region, to ensure that this process moves very quickly. So hopefully, by the end of this year, beginning of next year, we can at least in countries that are making some strong commitment to NCD prevention, we see that NCD prevention is integral to the Sustainable Development Agenda. And this is very, very important because we are now negotiating what will happen beyond 2015 in the United Nations. So what is the Sustainable Development Agenda post MDGs or post-2015. And I think this process of involving the UN agencies in this dialogue, ministries of planning in countries of the region, will help in ensuring that health is featured prominently in the discussions that will lead to the development of the new, well, if we can call it the new MDGs beyond 2015.
Thank you very much, Dr. Anwan. And in conclusion, we'd like to thank our speaker, Dr. Nishtar, Dr. Shehri, Dr. Muqdad, and Dr. Rajhi, and Dr. Hamada, and my co-chair. Ladies and gentlemen, thank you for your patience and attendance. Our next session at 11 o'clock.